The goal of this lecture is to talk about CPR and other types of non-medicational therapy and electrical therapy in the cardiovascular patient. The information that I've gotten from this is straight out of the American Heart Association 2010 standards, and it pretty much follows along with those very nicely. I have those EMS standards available for you on the Angel course shell, so you're welcome to go there and get them. So we'll get it going, and it starts with our chain of survival. It's a 5-link chain, and just like any chain, if you have a weak link in the chain, that's where it will fall apart in the hopes of increasing overall survival. We know that for a long time we have not increased survival rates from cardiac arrest, and we're better off if we can get some kind of prevention strategies in play to keep people from going into cardiac arrest in the first place. With that said, let's talk about where we are. We've got our change of survival, and that's recognition and activation of the EMS system, and certainly we've got to do a better job of getting the word out about EMS and that they can call 911. I realize that we're already pretty good. Most people know that if you're there, you're having a heart attack, to call 911. The problem that we have right now is that we don't do a very good job of relaying the information that somebody is actually having a heart attack. In other words, the first sign of an MI, and that's what I'm going to call it, a myocardial infarction, is an MI. And so instead of calling it a heart attack, I may slip and call it that, but I'm going to try to use medical terminology here and call it an MI. The problem is the people that are having an MI, their first stage is denial, and they don't see a need to call the EMS system. And we want to try to get that out there, to get the signs and symptoms associated with that out there. So recognition that there is an MI going on, and then activation of EMS. Obviously, if you're walking in a grocery store and you drop over dead in the aisle, that's going to not be a whole big thing here for people to get the concept that they have to call 911. So recognition that there is a problem, and activation of the EMS system. Once there is cardiac arrest, we want to get early CPR started. And the theory that we're trying to get to is, if you know how to drive a car, you should know how to do CPR. If it's nothing more than a 5-minute, 15-minute presentation on here's how to interlock the fingers and do good, effective, hard and fast compressions, then we're going to go a long way in trying to prevent heart attacks. We're going to talk about a case study in Seattle where that was the case. Then after CPR is initiated, then we want to start with rapid defibrillation, and we want to put defibrillators out in the public a little bit more than what we've got them now. We continue to grow in this capacity, but not at a fast enough clip. We want to get people on the chest and get a defibrillator there. Then we have effective ALS. That's where we come into play, and we're going to be talking a great deal more about that here in the coming weeks. And then an integrated post-cardiac arrest care, which may be hypothermic resuscitation or effective vasopressor therapy by ALS providers. So that's where we're going. We're going to be talking about the first 3 phases of this for this presentation. We're not really going to get into advanced life support at this point, or the integrated post-cardiac arrest care. We'll do that at a later phase this semester, probably in the coming weeks. So what's going to happen here? How many people are actually going to benefit from this, from increasing survival rates from this chain of survival and doing an effective job of it? And the reality is about 50% of those in Witness VFib could be benefited from a better look at what we're doing. So how aggressive do we need to be? I've talked about this before. If you can drive, you should be able to do CPR. All rescuers, regardless of training, should provide chest compressions. If you jumpstart a car, you can jumpstart a heart. The building blocks is that hands-only CPR. When 2010 standards came out, they did a very effective job of putting hands-only CPR commercials out there. I haven't seen a whole lot recently, though. But we got guys that were walking around with their hands and that kind of stuff with hands-only CPR. Probably ought to get that going again to re-emphasize its importance. And then as you get higher trained, then we can go ahead and add some of the rescue airway components to this, mouth-to-mouth, rescue breathing, that kind of stuff. But there is a significant number of studies that are still indicating, overseas mainly, indicating that CPR is effective when you do hands-only CPR, and not real effective when you stop to do ventilations. What used to be a 15 to 2 compression to ventilation ratio is now changed to 30. We're finding that it takes about 12 or 13 pumps to start till we actually start moving blood. So we want to minimize the time off the chest. The standard is no more than 10 seconds, but we go back to these standards again, and what I think that we need to drive home is the fact that 10 seconds is the standard, but the more we're off the chest, the less we're moving blood. The more we're off the chest, the less we're moving blood. So it can be a 10 seconds here, 10 seconds there, a total of 10 seconds, whatever it is, but the time you're off the chest is the time that you're not perfusing brain and body, and that's a big deal. So despite the fact that we're allowed, quote, quote, allowed to be off the chest for no more than 10 seconds, I want to reinforce how important it is to be on the chest as much as we possibly can. So the 30 to 2, I look to see what they do with the 2015 standards to see if that goes away or not. And then once you get them intubated, I think what's going to happen is that you'll get them intubated, and then you can get breaths whenever you have an opportunity to get breaths, 8 breaths per minute, something like that. But we're finding a severely diminished effect, positive effect, of ventilation therapy in CPR. And then we get the highest level trained at the top of the pyramid here, where it's multi-rescue or coordinated CPR, intubation, IV therapy, medications, full comprehensive care of the patient as we get to higher level training. But it starts with this hands-only CPR at the bottom of the pyramid. American Heart Association came out with a very simplified CPR concept, and that is if the patient has fallen unresponsive, they're not breathing, or they're doing what we call agonal respirations, gasping respirations, the breathing's not normal, the chances are they have slipped into a VFib cardiac arrest. At that point, we want to activate the emergency response system. General bystanders will go activate EMS and go find a defibrillator, and then begin hands-only CPR. That's the concept. So find them unresponsive, activate EMS, get a defibrillator, and start CPR. We start CPR right away. As soon as we get the defibrillator in, we can go ahead and check the rhythm. If the rhythm is a shockable rhythm, we'll shock the rhythm. Hard and fast, push hard, push fast. That's the idea of what we're going with CPR. Hard and fast for CPR. In the old days, the movie theaters used to, at least it was said, I'm not sure how true this is, but you would sit in a movie theater, you'd be watching a movie, and they would install one slide, one frame within the movie that had a big bucket of popcorn, overflowing with butter-filled popcorn. And the idea is that as that flips through that movie, it's just a flash on the screen that you wouldn't recognize with the naked eye, but your sub-psychiatry, your subconscious psych would recognize that you're hungry for popcorn and you go get popcorn. Again, I don't know how true that is, but I think it's a good concept. And whether it is true or it isn't true, I'm going to be much more brazen and open with my attempt to brainwash you into remembering CPR as the important aspect of what we're doing. So important that as we are in the lab, I want to see people on CPR. We got to be on the chest. We got to be moving blood. We perfuse the brain and body. The only way to do that is to move blood, and CPR is a way to get that done. So throughout the entire presentation, I've got over and over and over again, I'm going to bring these subliminal brainwashing type methods. I proudly announce brainwashing type methods to you to see if you can remember CPR. So let's get to the importance of defibrillation. The importance of defibrillation. VFib is the most common rhythm that we're going to see in patients who are in cardiac arrest. We used to say, well, that was the adult patient, but we're not really sure what the pediatric patient did. As a matter of fact, we assumed that the pediatric patient was asystolic. But that's not true. Research has shown that even the pediatric patient goes into VFib first, just for a shorter period of time before they go into asystole. And main treatment, the definitive treatment for ventricular fibrillation is defibrillation, and that's what we need to do. I've got a little stopwatch over here on this slide, and then a sudden decline, and we know that the faster we catch the patient, that they go into VFib and get CPR going and defibrillate them out of VFib, the faster we're going to get them, the better chance we have of getting them back. And then that steadily declines at a consistent rate over time. So there isn't anything that would say, oh, there's a magic drop-off or anything like that after a period of time. As minutes go by, the chance of bringing this patient back to a sustainable rhythm is unlikely. So defib success declines over time, and then VFib goes into asystole within only a few minutes, typically for most people. So we only have a few minutes to actually try to prolong that. That's exactly what CPR is doing. We're trying to prolong VFib. It doesn't cure VFib, it prolongs it. Instead of what would normally have been maybe 6 minutes, maybe we get an extra 3 out of somebody doing CPR, and that 3 minutes may be the time frame that we get the defibrillator there. So that's what we're looking for. We're just buying some time to see if we can get a defibrillator there and see if we can get this going. So our goal is to activate EMS, do immediate bystander CPR, get as many people trained as we possibly can, and then defibrillate that patient within 5 minutes. So again, my subliminal message: CPR, 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 CPR. I've emphasized it on every possible way that CPR is the most definitive care. I talked about a Seattle case study. This is the story of Seattle. Seattle is an incredibly progressive, aggressive, healthcare conscious city, probably the best healthcare conscious city in the United States. If there's a new product out or a new method of managing healthcare, Seattle is typically one of the first cities to come on board with this. And they did the same thing when defibrillation took off in the early 90s. And I'm exaggerating here, but the concept basically, Seattle said, if defib's going to save lives, we're going to teach people how to defib. We're going to put a defibrillator everywhere. You're not going to be able to spit, piss in Seattle without hitting a defibrillator because we care about the people that we're in. So that brings me to my defib here, defib there, defib everywhere. But the problem is, as they did that, they lost the emphasis on doing CPR. And they were more concerned with training people how to use defibrillators than they were with hands-on CPR, and then their survival rates actually declined. But you would think that that's a bad side of Seattle. Seattle caught on to this very quickly and reversed their trending, reversed their thought process, and went back to CPR, CPR, CPR. Just one more thing before we'll go ahead and then take a break from this one. The precordial thump, it's back. We have, if you have a patient who has a witnessed VFib, so patient goes down in front of you and goes into VFib, there is no defibrillation immediately available, meaning the patient is not hooked up to pads, you don't have a cardiac monitor on them, no defib immediately available, then we're going to do a precordial thump. This comes from the elbow, just the power that comes from an elbow. This is not a WWE wrestling move that comes from the third rope, catapulting down. We used to whack them real hard across the chest. That's not what this is about. This is about a sudden jolt to the chest from the point of the elbow, about that, with the sudden downward thrust of the fist into the upper sternal or mid-sternal cavity with a sharp strike. With only the power that you have and coming from the elbow. And the idea is that's going to deliver roughly 5 joules of electricity, and we're going to see if that's enough to get them going. And we'll stop the tape there. We're going to go into the next portion, CPR 2, and talk about the importance of defibrillation and a little bit more about the different types of waveforms associated with defibrillation. Part 2 coming up.